Good morning, ladies and gentlemen. Today we are going to talk about the normal pregnancy and the things we need to know in the first trimester. You see, many of the complications that happen during the first trimester are worth studying because half of conceptions miscarry before 12 weeks of pregnancy. Now there are certain laboratory parameters we need to know to see how the pregnancy is progressing. Quantitative beta HCG. Quantitative beta HCG levels are correlated to the age of pregnancy and specific ultrasounding findings, and by correlating them we can know how the pregnancy is progressing. At least two measurements of beta HCG taken 2 or 3 days apart can help determine if a pregnancy is progressing normally. Quantitative beta HCG should double every 2 to 3 days during weeks 4 to 8 in normal early pregnancy. So the beta HCG should double every 2 to 3 days. And also the value of beta HCG is also important. Correlation of beta HCG with an ultrasound exam gives the most information about the status of the pregnancy. When the beta HCG reaches approximately 1800 milli-international units per ml IRP, transvaginal scanning should show the gestational sac. So this value 1800 is very important, and that is the time when the transvaginal ultrasound display the gestational sac. And also the progesterone level. Progesterone levels can also help predict pregnancy outcome in the first 8 weeks of gestation. In contrast to raising beta HCG levels in normal pregnancy, serum progesterone levels remain constant during the first 9 to 10 weeks of gestation. Progesterone levels of less than 5 nanogram per ml are more likely to be associated with a poor pregnancy outcome, while a progesterone level of greater than 25 nanograms per ml is strongly associated with a living intrauterine pregnancy. So progesterone levels less than 5, poor pregnancy outcome, whereas greater than 25 nanograms per ml, a living intrauterine pregnancy. So that value is important. Now coming to the indications of ultrasonography. Ultrasonography has been increasingly used in the first trimester of pregnancy to identify so many causes. Among the most important, I read suspected miscarriage or fetal death, vaginal bleeding, gestational age assessment in cases of uncertain dates, adjunct to special procedures such as chorionic villus sampling, suspected multiple gestation, suspected hydatiform mole, suspected ectopic pregnancy, intrauterine contraceptive device localization, suspected uterine abnormality, size dates discrepancy, and evaluation of maternal pelvic masses found clinically. Routine ultrasound in early pregnancy appears to enable better gestational age assessment, earlier detection of multiple pregnancies, and earlier detection of clinically unsuspected fetal malformation at a time when termination of pregnancy is possible. Now coming to first trimester sonography. When first trimester sonography is performed, both transabdominal and transvaginal imaging techniques should be available. Transabdominal scanning is performed with transducers in 3 to 5 megahertz range, transvaginal scanning with higher frequencies in the 5 to 7 megahertz range. Now coming to sonographic findings of a normal pregnancy. Between the 5th and 7th menstrual weeks of pregnancy, transvaginal ultrasound scanning with a 5 to 7 megahertz transducer will reveal the gestational sac, yolk sac, and embryo in that order. Gestational sac is not visible sonographically until the beta HCG level reaches 1800 milli-international units per MI IRP. Now, how to identify normal gestational sac? There are 3 things to remember to identify normal gestational sac. Number 1, it is round in shape. Number 2, it is localized in the uterine fundus. Number 3, it will have an echogenic ring surrounding the sac. Now we need to remember that the fluid in the gestational sac is not extraembryonic serum, but it is extraembryonic serum. It's not amniotic fluid. During the 7th menstrual week, the embryo appears and cardiac activity becomes visible. During the 7th menstrual week, that is when the cardiac activity becomes visible. Transvaginal scanning will identify the embryo about 1 week earlier than transabdominal scanning. Embryonic cardiac activity is almost always visible by the time of the crown rump length is 5 millimeters. By the time crown rump length is 5 millimeters, embryonic cardiac activity is visible. When first visible, the embryonic heart rate is 100 per minute. It rises rapidly 180 before settling back down to the familiar 120 to 160 range when it can be heard by handheld Doppler. M-mode ultrasound can be used to document embryonic cardiac activity and its rate. With modern real-time scanning by the transvaginal approach, the embryo is visible by the 6th week, and gestational age can be assessed by directly measuring the crown rump length. After the embryo is visible and between 8 and 13 weeks, gestational age can be calculated by a simple formula. Menstrual age in weeks is equal to crown rump length in centimeters plus 6.5. That is, menstrual age in weeks is equals to crown rump length in centimeters plus 6.5. So basically, ladies and gentlemen, we use sonography in association with beta HCG and progesterone to determine the normal progress of first trimester pregnancy.